Welcome to week 2 of module 4. We'll talk about setting tidal volumes in ARDS beyond what we learned from the ARMA trial done more than 2 decades ago. However, we'll start discussing the intervention arm. In the lung protective ventilation group, tidal volumes were decreased to 6 mL per kilogram of predicted body weight right after randomization and kept between 4 to 8 mL per kg. Tidal volumes were lowered from 6 mL per kilogram for plateau pressures greater than 30 centimeters of water. Remember, the plateau pressure is our surrogate for end inspiratory alveolar pressures, a key driver of overdistension. If the plateau was elevated, tidal volumes were reduced all the way down to 4 mL per kg. However, if there was respiratory acidosis with a pH less than 715, despite increasing the respiratory rate up to 35 breaths per minute, plateau pressures above goal were accepted and tidal volumes were not reduced. On the other hand, in the presence of certain abnormal patient-ventilator interactions, which we'll cover in Module 5, tidal volumes could be increased to 7 or even 8 mL per kilogram. A couple of decades after the ARMA trial, have we learned anything new? Let's dive deeper. What do you think if someone said that they would ventilate all patients with 500 mL? You'll probably correctly point out that this is a terrible idea. Why? Well, because total lung size is different among different individuals. We wouldn't want to ventilate these two sets of lungs with the same tidal volume. But how do we estimate total lung size? Well, we use height and gender. Guess what? Predicted and ideal body weight take into account height and gender, and they correlate well with total lung size. So when we say we are delivering 6 mL per kilogram of predicted body weight, we're indexing the amount of volume we give to a surrogate of total lung volume. So the bigger the patient's lung size, the larger the tidal volume they get, and vice versa. That makes sense, right? Well, picture this scenario where we have two patients of the same gender and of the same height. In fact, they had exactly the same total lung size. Both also had severe influenza leading to ARDS. One had severe ARDS with extensive alveolar consolidations, while the other one has a more mild process with much less airspace filling. Would you want to give these two patients the same tidal volume? If we dose tidal volumes based on mLs per kilogram of predicted body weight, they will get the same tidal volumes. What is the problem with it though? The same tidal volume will occupy much less alveolar units in the severe ARDS patient, leading to regional alveolar overdistension, a key culprit of villi. Stating this in a different way, although these two patients have the same total lung size, their functional lung size are very different due to extensive consolidations in the patient on the right. So we agree that indexing our tidal volumes for markers of total lung size may not be optimal. But what could be a surrogate of functional lung size that we could use to index our tidal volumes? Well, what is a clinically available parameter that varies with changes in functional lung size? The answer is compliance. The more of our lungs we have available for ventilation, the higher is our compliance. We could dose tidal volumes by units of compliance. We could communicate as, I want 15 mL per each unit of compliance. And if compliance was 30, we would give 450 mL of tidal volumes. But that would be complicated. There is an easier way to do this. Let's look at the equation for static or lung chest wall compliance. As you remember, it states that compliance equals tidal volume divided by the difference of plateau and PEEP. If we rearrange the terms here, we'll get that plateau minus PEEP equals tidal volumes divided by compliance. What we're saying here is that our driving pressure, plateau minus PEEP, is mathematically an expression of our tidal volumes indexed or corrected by compliance. So if you want to titrate your tidal volume by compliance, a marker of functional lung size, all you need to do is titrate it to a certain driving pressure. Back to our two patients, for the same tidal volume, the one with more severe ARDS will have a higher driving pressure since their functional lung size is smaller. If we want to avoid overdistending their smaller functional portion of the lungs, also called the baby lung, we will need to reduce their tidal volume. But what is an ideal driving pressure? Based on retrospective analysis, a goal of less than 15 centimeters of water is usually sought clinically. A word of caution applies that although titrating tidal volumes to driving pressure makes sense physiologically, we do not have randomized controlled trial data confirming this hypothesis. The best data available consists of reanalysis of trial data suggesting that the drop in driving pressure may be the actual mediator of benefit in trials of lung protective ventilation. There is one last thought I'd like to share with those who fell in love with advanced respiratory system mechanics. You may have noticed that we were using lung chest wall compliance as our surrogate for functional lung size to index tidal volumes. This measurement is affected by chest wall compliance though. To be purists, we could actually index tidal volumes by true lung compliance, as long as we have an esophageal balloon probe. In which case, the transpulmonary driving pressure, which we discussed a few weeks ago, would equal tidal volumes indexed or corrected by lung compliance. Although this is certainly interesting, there is virtually no high-quality data pointing towards which values of transpulmonary driving pressures we should pursue. But that is it for today. I will see you in the next week.